Start this as I give a lot of talks, and I never feel more nervous when I'm talking to groups of people like you, because I'm from a completely different perspective. I see it from a professional perspective. I don't. Well, that's not true. Of course I do. But it's. I have a different role to play in people who've been affected by meningitis. And in preparing for talks like this, I always get quite nervous because I don't want to overdo it or underdo it. And I don't want to use surgical slides and do all the tricks that I get away with when I'm talking to doctors and people like that. And I'm always reminded, but I was at one of the MRF conferences, and I was doing a Q&A, and at the end I asked a question of the audience, and I remember someone I'd got to know very well because I was looking after his daughter, and I said, you know, what can I or what can't I say? And he said, look, just tell us what you know, because there's nothing you can say that's going to make it any worse. And that really resonates with me. The reason I say that is I'm just going to go through a medical version of what treatment we are able to provide for people who've been affected with meningitis in its many forms. That's all I can do for you, and I hope it's useful. If I can make the computer work, that is, of course. There we are. And so this is my brief. I've got to talk to you about my specialism and experience, which won't take long. Orthopaedic complications of meningitis, particularly limb loss, and then techniques for management of people with limb deficiency. And this is something that we've learned how to do. When I was in medical school, the chances of surviving meningococcal septicemia were actually single-figure %. And as that's improved with substantial advances in general medical care, intensive care, etc., we were faced with problems that we didn't have solutions to. And so, as the reality of medicine and surgery is, we had to be innovative, and we had to find out what was not only successful but also appropriate. And I've been looking after people with meningococcal disease probably for the last 25 plus years. And these are just some of the things we've learned. So my credentials, so I work in Bristol, and our catchment is pretty much the whole of the Southwest and South Wales. So I've been involved in some way with the majority of children that have had meningococcal septicemia over the last 20 plus years. And this is you always have to show a picture of your hospital. That's where I work. It's in the centre of Bristol. And we set up quite quickly. One of the things I wanted to do was you know, one of the nonsense things about the way we practice medicine is we get people to come one week to see one person, then they have to come the next week to see another person. And I thought this is just nonsensical. And so we put together, I just got all the people who were likely to be useful to people. This is all children. My context is children. I don't look after adult patients. Anyone who might be able to lend a hand, I just got into the same room, and then we started inviting patients, and that became quite an established meningococcal septicemia clinic. And it's been working now for years, and we've got 3 plastic surgeons who I think are probably, from a surgical point of view, they're the most important thing, because most or a lot of the problems are with the soft tissue damage caused by the septicemic illness. And there's me sort of ringmastering it, really, just sort of making everyone turn up at the right place. That's pretty much my role. And then really important people, the orthotics people, the prosthetics people. You know, these are the people that make the absolute difference between good and not so good function. Physiotherapists who are well used to dealing with people with burns, and the problems with the skin and the soft tissues following meningitis are very similar. And one of my colleagues in limb reconstruction physiotherapy, who just gives her input into, you know, how to make the limbs work better. And one of my colleagues, Sharon, who's a limb reconstruction nurse, who again, adding the skills that we've learned from other areas, putting them in to look after this particular group of patients. And the complications, really, I think about them as the ones that happen in the first few hours and the ones that happen in the first few days, the first few weeks, and in the longer term. And Mike, you've just articulated all of them. I've got really nothing to add. You've just said and shown what it feels like, not only what it looks like, but what it feels like to have this to happen to you. But from my point of view, this is someone that, yeah, that's what it starts as. And I hope this isn't too upsetting to people. I know you've all been through this, but as I always said, I can't make it any worse. But from a physiological point of view, often, probably, 60, 70% of people will recover from this, and they don't need any long-term input. That's obviously what we strive and hope for. But as part of the disease process, it creates problems with the circulation. It reduces blood pressure. It reduces the way that blood's pushed around, particularly to the peripheries. And what the body does is to save the brain, the heart, which are vitally, without those, everything else is off. It will divert blood from other places, particularly from the limbs and the peripheries, like the nose, the earlobes, etc. Also, as part of the disease, you get thrombosis in the vessels. So not only is the blood supply suboptimal, but also you get clots in the small vessel, which basically turns the blood off. And that's what you were describing that happened to your hands and your legs. As part of the treatment, again, that compounds, although it's essential and life-saving, it sometimes is at the expense of complications with the limbs. And if you have to put catheters into arteries, into veins, that also interferes with circulation. And some of the drugs that keep the heart beating cause the circulation in the periphery to deteriorate, and it compounds the effect. So overall, blood stops going to the peripheries, the tissue dies, and that's where the limb loss happens. And it's all about loss of blood to the periphery. Oops. We want recovery. Often what happens is recovery with growth arrest. And quite early on in my experience with this condition, it seemed that people had got away without complication, but only to find that several years later, the growth of the skeleton was affected. And so the growth plate, where growth occurs in the growing child, is very sensitive to loss of oxygen or reduced circulation. So that's something that I'm always on the lookout for, even if a limb is preserved. And that line there is where it should be growing. And that is where the growth plate has been destroyed and it forms in bone. And that is the shape of the ankle, which is just very abnormal. And to try to show you in a different way, that's where the hip is. This is an X-ray of someone standing up. That's where the knee is, and that's where the ankle is. And if you draw a line between the hip and the ankle, it's supposed to go through the knee. And that just shows you the degree of crookedness of that limb. And you don't need an imagination to understand why that's a very difficult limb to walk on. And so what we've learned, the surgical problems are the skin condition, the scarring around where you'd otherwise want to do your operations is such that conventional surgery, making an incision, operating on a bone, putting a plate on it, just won't work because the skin and the soft tissues won't heal properly. And so we use techniques that we use in other situations to basically, through very small incisions, but using a cage on the outside, divide the bone and move it around so it becomes straight. And that's something we've done consistently over quite a long time. And we have a reasonable amount of experience. We know what will work, what won't work, but it certainly gives us an option to do operations to straighten limbs in people with very badly affected soft tissues. And if the video will work, that's the leg that the X-ray was taken from, and that now is functioning very, very much better. But if you look at the scarring around the knee, a conventional operation there, I say conventional, plates, screws, etc., just wouldn't heal and was likely to get infected and probably make things worse. And then there's a situation with limb loss, or limb loss and growth arrest, because in the retained part of the limb, there's still a growing end. And if that's affected in the way I've described, then often the residual limb will grow out of line, making it very difficult to continue to wear a prosthetic. And these, all the photographs I show, I know these people. I have consent and permission to do this. Otherwise, I was thinking about blanking the faces out, but you lose the whole story if you do that. And all these are either in the public domain or I have permission to use. And this is a patient who I've got to know very well over the years. And this is, you know, what you've just described as well. It's limb loss. It's a change. It's a life-changing event. The problem is that that's not where it ends, particularly if you're growing, because there are a number of areas in which there can be a deterioration which prevents comfortable or effective prosthetic use. Often the soft tissues that are at the end of the limb are very scarred, and if they are stuck to the bone, they'll abrade and they'll rub, and it's like wearing in a pair of shoes. It will just cause blisters and pain, and you won't be able to use it. And when I'm talking to people who've lost limbs, this is now the foot. This is the part of the body that now interacts with the ground, and so it's got to be as comfortable as my foot. Otherwise, they'll not be able to walk properly. And so, some of the surgery that we undertake is to improve the soft tissue coverage at the end of the residual bone. And we use plastic surgery techniques, we use orthopedic surgery techniques to do that. But that's not an uncommon procedure in someone who has lost limb following this condition. Another common condition, if you can see my mouse, in the growing, this is the growth plate. And one of the features of childhood, bone in childhood, is that the ends of the bone will continue to grow and become spiky. And if you see where my arrow is, they're sharp shards of bone, and irrespective of how good the soft tissues are, that will be uncomfortable. And it's often, or it's necessary to remove those bone ends to allow comfortable prosthetic use. It's the sort of deal I have with the patients I look after. I don't want them to come and just present themselves to clinic. This is so old fashioned. I just say, look, if you know what it feels like, if you've got a deteriorating pain, feeling a piece of bone, just give us a ring and we'll arrange to meet and do something on the same day. And it works very efficiently. And in the right patient who understands and who's been through that system, I think it's quite an efficient way of advising. Another problem is the nerves that are left behind after a limb is lost. A nerve is a very sensitive tissue, and when it's divided, it only knows how to do one thing. It tries to grow, it tries to heal, and it will form lumps of nerve. And these are what are called neuromas, and these are lumps of nerve tissue, which if you touch them, they can be exquisitely tender. And they also will cause problems, well, very, very substantial problems with comfortable prosthetic wear. And so this is just a surgical specimen of a nerve that has been removed exactly for that reason. And then growth disturbance. This is a growth plate, and so is this. And this is a scar. This is an area of damage to the growth plate, which will mean that that will grow out of line. It will become crooked where it was previously straight. And so that will lead to deformity and shortening. And if you look at the top slide, that is a residual, that's the knee, and that's the residual limb below the knee, which is pointing at about 45 degrees sideways. Now, if you attach a prosthesis to that, it will be at 45 degrees sideways, and it just won't be possible to use that in an efficient way. And so some of the people we've looked after have required bone surgery on the limb that's left behind. And this is a picture, it's a surgical picture of a limb which is short. There's a bony prominence where my arrow is, and it's also out of line. The problem with it, it's very short, and it's not suitable for an efficient prosthesis. And again, there's a lot of discussion that goes into this because there is no one good option. There are always a number of different considerations. And so it's by negotiation we come up with what's likely to work for an individual. And so this is using techniques we use for limb lengthening. This is a cage that goes with wires into the bone, and you divide the bone between those two rings, and gradually you just stretch it. And that's how we make limbs longer in a variety of other conditions. And we've just adapted that to make residual limbs longer in this condition. And in this case, we work very closely with our prosthetics people. This was an artificial foot, a prosthetic foot attached to the limb to allow this young lady to run around while she was being treated. So it was difficult, but it was not anything like as difficult as we all thought. And this is what it looks like. So if you look at these, I've tried to match them up. That's in the same place. That has moved to there. And so that limb is now this much longer. It's 7 centimeters longer, which will allow substantially better prosthetic options. It will just allow much more efficient use of a below knee prosthesis. And so I haven't got much more to say apart from, you know, that lady's taught me, the person I've just shown you, a lady called Lavana, who's now grown up, and she's taught me that people with amputations will have a good life and they'll have plenty of opportunity. And I've got to know my patients quite well over a long period of time. And this is what she gets up to when she's not, you know, having to attend hospital appointments. She's a very, very accomplished competitive swimmer. And I just found this recently. She's also a very clever young woman as well, who's just passed her exams. And I didn't know that. So it's a shame on me. And Lydia, who's the person in the first picture, and it was actually Lydia's dad who told me the bit about you can't make it any worse. She'll tell me, she's taught me as well that people with amputation will have a good life with plenty of opportunities. And this is, you know, her, you know, in the dark days that you described. And this is who she is when she's a little girl. And this is who she is when she's a bit older. She's now a young woman. I don't see her anymore. She's no need for the likes of me. But I was called to the TV set one day by my wife who said, look, is this one of your patients? And what I didn't know is she'd asked for me to operate on her, probably 4 or 5 weeks before something very important. I didn't know what it was, but this is her at the cenotaph laying a wreath about 4 weeks or so after quite considerable surgery. Now, I don't know what tough is, but it's certainly, that's what it looks like. And she is one of the toughest people who I think I've ever met. And finally, this is a young man who I hope I became friends with him. And it's nothing to do with meningitis. It's just the other opportunities that life gives you. And this is what happened to him when he was a baby. And I met him, you know, very early on. I got to know him because he taught me again that people who have amputations will have a good life and will have plenty of opportunities. And we organize probably to see each other more possibly than we need to for medical reasons, because he is a massive Tottenham Hotspur supporter. And so am I. And most of the time that we meet, we talk about football. We have to remember, I have to remember to you know, that there is a medical perspective to this as well, but we generally talk about soccer. And he showed, I think his mum told me about this video, and I saw this. And the reason I show it is because if this had happened to me when I was his age, I'd still be talking about it now. This is something that I'd still remember as quite an old man. It happened to me as a boy, as a Tottenham supporter.
Marshall, he shoots! Marshall to Davis. Marshall takes the ball again. What a lovely ball, straight over to Tom Carroll. Back to Ben Davis and back to Marshall. Great control and back again. Brilliant.
And so if I could have had the opportunity, as Marshall did, to kick a ball around with the Spurs boys, I think my life would be complete. I hope that is useful. I hope it's interesting. I hope it's not inappropriate in any way. But one of the things that I've learned a huge amount from looking after this group of patients. And I hope we've been able to provide something of use to them. And thank you for your attention.